Hello everyone, welcome to the Prof exam series. Through this series of videos, I would like to discuss about the very important questions pertaining to your upcoming university exams. I'd like to start with the systemic pathology. In this first video, I will be discussing about two very important topics. One is uveal melanoma and number two is retinoblastoma. Both are very commonly asked short note question, very repeated question in your university exam. I will be using only Robbins for teaching. I will be discussing these topics very briefly, very precisely, so that you can remember these points as hints, and you can write elaborately, in your exams. I will be discussing under the following headings. Not only these topics, in the upcoming videos also, I will be discussing under these headings only. First, I will be discussing what is that disease. I will be discussing a brief introduction, pathogenesis, morphology, that is gross as well as the histopathological features, some clinical features, so that's how I would like to end the video, fine. And first chapter I would like to discuss in systemic pathology is disease of the eye. As I have already told, I would like to discuss two important topics. One is uveal melanoma and another one is retinoblastoma. Fine. So now let us discuss about the first topic, the first and foremost topic, that is uveal melanoma. See, what do you mean by uvea? As you all know, uvea is one of the vascular structure of the eye. It is made up of iris, choroid and ciliary body. Just you have to know some anatomy, right? Or else I will be saying uveal melanoma, so you should know what is uvea. It composes of iris, choroid and ciliary body. These are the important structures which actually composes of the uvea. And remember, out of that, choroid is a highly vascular structure. So just remember this. The first and foremost condition we are going to see is what we call as uveal melanoma. So melanoma, malignant melanoma, or melanoma as such, it's a malignant tumor. So of course, for a malignant tumor to arise, there should be some precursor lesions. So first what you are going to write? You are going to write the anatomy, then you will write uveal melanoma. What are the precursor lesion of uveal melanoma? The answer is uveal nevus. Uveal nevus. What do you mean by nevus? It is nothing else but an accumulation of melanocytes which will produce some pigmentation. So uveal melanoma, it is the most common primary intraocular malignancy of the adult. Fine. Then a brief introduction about the epidemiology. Remember, it is very common in United States as well as in the Caucasian population. Coming into the pathogenesis, the pathogenesis of the uveal melanoma is same as that of the pathogenesis of the malignant melanoma. So I would like to just say this pathogenesis in the form of a flowchart. Fine. So we have a very, very important mutation called BRAF. What is that? BRAF mutation. Actually, this BRAF is nothing else but it is actually a type of cell proliferation regulator. Whenever there is a mutation of this BRAF, what will happen? There will be uncontrolled proliferation of the cell that is responsible for cell signaling pathway activation. What are the pathways which are getting activated? Number one is mitogen activated protein kinase pathway. So that is the most common pathway to be activated, which results in uncontrolled proliferation of the melanocyte, leading to uveal melanoma. So what is the first step? BRAF mutation. Second step, what will happen? There will be a gain of function mutation, because whenever there is a gain of function mutation only, this gene will be overactive. So that is mitogen activated protein kinase pathway will be activating. That is responsible for uncontrolled cellular proliferation of the melanocytes, leading to uveal melanoma. What are the other mutations which are seen? One is called GNAQ and GNA11. That is GNA11 and GNAQ. We call it as GNAQ and GNA11. Fine. These are the other mutations which are seen in case of uveal melanoma. So that finishes the pathogenesis. As you can see this, you can see a very pigmented lesions, right? A darkly pigmented lesions you can see in the uvea. This is actually called as the uveal melanoma. Fine. Then coming into the morphology. It is a very, very small question. Morphology, since we won't completely do enucleation or evisceration of the eye. That means we will not completely remove the eyeball. A complete removal of the eyeball is not the treatment of choice in case of uveal melanoma. There is no particular gross findings. But histopathologically, we have some important findings that you have to remember. Number one, uveal melanoma has two types of cells. Remember, one is called as the spindle type of cells, and another one is called as the epithelioid cells. Spindle cells, name indicates they are fusiform in shape. Epithelioid cells, they are spherical in shape and they have greater cytological atypicality. Okay, fine. And another very important thing you remember, this uveal melanoma shows vasculogenic mimicry. What do you mean by vasculogenic mimicry? That is, they will what themselves connect to the blood vessels, and they serve as an extravascular conduit for the transport of plasma as well as the blood components. Okay, that means uveal melanomas are highly vasculogenic tumors, and hence they spread exclusively by what hematogenous route. Okay, that is very important. And remember, the most common site of metastasis of the uveal melanoma is liver. What are the clinical features? The patient may present with visual symptoms, okay, and glaucoma. The prognosis, it depends upon the size of the tumor, the depth of the tumor, the type of the tumor, okay, whether it is a spindle cells or that is epithelial cells, and the proliferative index. Okay, these are the various factors which depends upon the these are the various prognostic factors for the uveal melanoma. Okay, fine. Yes. So what are the targeted therapies? We have to target the BRAF mutation as well as the MAPK signaling pathway. Okay, that finishes uveal melanoma, and next we will go for the next question, that is called as retinoblastoma. So retinoblastoma, remember, it is again the most common primary intraocular malignancy of the children. Okay, intraocular malignancy of the children. I don't want to discuss about what to say the etiopathogenesis of the retinoblastoma, because retinoblastoma pathogenesis is in detail discussed in the chapter neoplasia. Okay, there you will be discussing mainly about two important tumor suppressor gene. One is P53 and another one is what we call as retinoblastoma. So the same pathways, we have Knudsen's two-hit hypothesis, the first hit and second hit. Am I right? So all those things you have to write in the pathogenesis of retinoblastoma. Now I will be saying only just very few salient features of retinoblastoma. Rest again, don't worry. Again I will be discussing the retinoblastoma in neoplasia as well as in childhood diseases. Okay, again I will be covering there. Okay, so remember here, which is the germline mutation of retinoblastoma allele. Okay, fine. So just coming into the morphology, remember we have two types of retinoblastoma. One is actually called as the hereditary retinoblastoma, and another is what we call as the sporadic type of retinoblastoma. Again, I will discuss this in neoplasia chapter, so no worries. Fine. So you can see this is the gross photograph of a retinoblastoma. Yes, how can you describe this gross features of retinoblastoma? It looks like a well circumscribed, homogeneously enlarged intraocular mass. This is the gross description of retinoblastoma. Coming into the histopathology of features of retinoblastoma, it is actually called as a rosette formation. The characteristic type of rosettes which is seen in retinoblastoma is a true rosette. What do you mean by true rosette? True rosette means there will be some flower, okay, petal shaped arrangement, and in the center it should be empty. We have something called as pseudo rosettes. Okay, we have something called as pseudo rosettes in which the center, instead of empty, it will be filled with some material. Here in retinoblastoma, we have something called as Flexner-Winterstein rosettes. Okay, Flexner-Winterstein rosettes. What are they? They are nothing else but a collection of small round cells with a hyperchromatic nuclei. Okay, and the empty. Okay, the central part of this, it looks like a flower like this. Okay, it looks like a flower like this. This is called Flexner-Winterstein rosettes, and here it is empty. That is why it is called a true rosette. Where we have something called pseudo rosettes. Okay, that is called Homer-right pseudorosettes, which will be seen in case of neuroblastoma, nephroblastoma. All those conditions, it is called a pseudorosette. Why it is called a pseudo in medulloblastoma? In all these are called as what they are called as pseudorosettes. Why? Because instead of this empty, they will be filled with something called as neuropil. Okay, neuropil is nothing else but an eosinophilic material. Okay, here it is empty. That is why the Flexner-Winterstein rosettes, which are seen in retinoblastoma, are called as what? True rosette. Okay, remember. Again, retinoblastoma, they are highly vascular tumors. Okay, they are highly vascular tumors, and remember, it undergo dystrophic calcification. Okay, I think this has been asked as an MCQ in your last year university exam question. Which of the following tumors undergo dystrophic calcification? Answer was retinoblastoma. Remember, retinoblastoma undergo dystrophic calcification. Okay, fine. And the rest of the features, clinical features, everything I will again discuss in neoplasia with pathogenesis. Okay, and as well as in childhood diseases, retinoblastoma will be discussed again. And remember, here like in uveal melanoma, the prognosis depends upon two important factors. One is extraocular extension, and number two is invasion along the optic nerve. Okay, invasion along the optic nerve as well as choroidal invasion. Okay, choroidal invasion, that means vascular invasion. Okay, that is again like our uveal melanoma, it also spreads through hematogenous routes. Remember, uveal melanoma is a highly vascular tumor. That is why it spreads only by hematogenous route, and the most common site of metastasis in uveal melanoma is liver. Okay, so this finishes the two very important questions in eyes. With that, I will be sending the next video, which will be based on CNS, that is central nervous system, where I will be discussing the CNS infection and CNS tumors specifically. Thank you.